Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, welcome to our webinar, The Role of Neuroradiology in the Ongoing Safety Monitoring and Care of Patients Receiving Anti-Amyloid Therapy for Early Alzheimer's Disease. My name is Patrice Cogslow. I am a neuroradiologist at Mayo Clinic in Rochester, Minnesota. Today, we will be discussing amyloid-related imaging abnormalities, or ARIA, the relevant imaging and clinical workflows. We'll start with a description of ARIA and its mechanism, discuss risk factors, imaging features, and clinical symptoms. We'll focus then on MRI for monitoring of ARIA, interpretation and communication of imaging findings, and end with some cases. In this webinar, we'll build upon information presented in the prior two webinars in this series, discussing Alzheimer's disease pathophysiology, diagnosis, and prognosis. Amyloid-related imaging abnormalities, or ARIA, are imaging findings of edema, ARIA-E, and hemorrhage, ARIA-H, that occur in the setting of immunotherapies targeting beta amyloid. ARIA is thought to result from the leakage of fluid and blood products when there is loss of vascular integrity, with the results of amyloid clearance from both the parenchyma and vessel wall with these therapies. ARIA rates in phase 3 clinical trials of lecanemab and donanemab are shown here. For ARIA-E, there's an incidence of about 13% and 24% respectively with lecanemab and donanemab, and ARIA-H rates of about 17 and 31% respectively. I'll note that the ARIA rates between these two trials are not directly comparable due to differences in these trials, including dosing and patient populations. One common finding, though, between these trials as well as others of amyloid targeting therapies, that ARIA rates are higher in ApoE4 carriers versus non-carriers. For example, in ApoE4 homozygotes, ARIA-E rates with lecanemab were about 33% in homozygotes compared to about 5% in non-carriers. And for donanemab, about 41% in ApoE4 homozygotes compared to 16% in non-carriers. Additional risk factors for ARIA include older age, the presence of microhemorrhages on the baseline pretreatment MRI, which is an indicator of cerebral amyloid angiopathy, history of prior stroke, and antithrombotic use. So those are risk factors related to patient features. There's also risk factors associated with the drug treatment. So the specific drug target and drug dose affect ARIA rates, as well as timing in the treatment course, with ARIA being more common earlier in the treatment course when amyloid removal is thought to be the greatest. ARIA in our imaging findings and most commonly occurs without any clinical symptoms. If clinical symptoms do occur, they're generally mild and non-specific. And there have been cases of infrequent, severe, symptomatic cases that may require hospitalization and close monitoring. And there have been rare recorded fatal outcomes, a few of these including cases where patients on an amyloid targeting therapy presented with stroke-like symptoms and received thrombolysis. Next, we'll move into the imaging findings of ARIA. So first, ARIA-E, with the E standing for edema or sulcal effusion. ARIA-E is identified on the T2 flare sequence. When there's a leakage of fluid into the parenchyma, the result is vasogenic edema as shown on the top image. This is T2 hyperintense signal in the white matter. The signal abnormality may involve the cortex and have associated cortical swelling. This is differentiated from acute ischemia by the absence of diffusion restriction. If there's leakage of fluid into the leptomeninges, the result is a sulcal effusion as shown on the bottom image. ARIA has a predilection for the occipital and temporal lobes, and ARIA-E is a transient phenomenon. Go through a few cases demonstrating that. First, here we have a baseline of pretreatment T2 flare. Post-dosing, there's a new region of left frontal edema, small overlying sulcal effusion. Repeat imaging was performed the next month. We see improvement in that region of edema and resolution by 2 months later. So again, ARIA-E transient often resolves over the course of a few months. Here's another example of ARIA-E, again starting with that pretreatment or baseline T2 flare. Post-dosing, there was a new right parietal sulcal effusion. Patient was followed with MRI again the next month. That right parietal sulcal effusion has improved, but there's a new right frontal effusion. Again, the next month, this has resolved. Next, ARIA-H. ARIA-H is identified with heme-sensitive sequence or gradient echo or susceptibility-weighted imaging and occurs in the form of microhemorrhages or superficial siderosis. Importantly, these both must be differentiated from vessels, which can be aided, especially by close comparison with that pretreatment baseline exam. ARIA-H often occurs along with ARIA-E, and when it does, the microhemorrhages occur in the same location as the ARIA-E and often clustered as seen in this top example. When ARIA is identified, it must be given a radiographic ARIA severity score, and this is a score of mild, moderate, or severe for each ARIA-E, ARIA-H microhemorrhages, and ARIA-H superficial siderosis. ARIA-E is graded based upon the number of regions of contiguous flare signal abnormality and the greatest linear dimension of the largest region. ARIA-H microhemorrhages is graded based upon the cumulative number of new microhemorrhages since starting treatment, so compared to that pretreatment baseline MRI. And ARIA-H superficial siderosis by the new regions of siderosis. The radiographic ARIA severity score is then used along with any clinical symptoms to determine a patient's eligibility for continued drug dosing. In a patient who has no symptoms related to ARIA and mild radiographic ARIA, dosing may be continued. With moderate or severe radiographic ARIA or any clinical symptoms, dosing should be suspended, and monthly MRI is performed until the resolution of ARIA-E and stabilization of ARIA-H. At that point, clinical judgment will be used to determine the appropriateness of resuming dosing. Per appropriate use recommendations, it is recommended that a patient who has had severe radiographic ARIA or severe clinical symptoms while on an amyloid targeting therapy, then those patients' dosing be permanently discontinued. We've mentioned multiple brain MRIs be performed during the course of amyloid targeting therapy. And shown here are both the dosing regimens as well as MRI schedules for lecanemab and donanemab. For both of these, a recent brain MRI must be performed prior to the initiation of therapy, and that is used to evaluate for any exclusionary findings, which we'll provide details on later, as well as provide a baseline for future comparison. Then multiple brain MRIs are required during the first year of therapy to evaluate for ARIA. If ARIA is identified, again, monthly brain MRIs until the resolution of ARIA-E and stabilization of ARIA-H. Additionally, if a patient on amyloid targeting therapy develops new symptoms, new neurologic symptoms, a brain MRI is warranted. So based upon those needs for MRI, we're going to discuss imaging workflows according to 3 patient scenarios. So the baseline or pretreatment enrollment MRI. Number 2, the asymptomatic patient presenting for ARIA monitoring. And third, a patient on amyloid targeting therapy who has developed new symptoms. For each of these, we'll go through proposed imaging workflows going through from the placement of an order for the brain MRI to communication of the relevant findings. So first, for the MRI brain orders, we need to be clear with the MRI brain orders to indicate, is this a patient with suspected Alzheimer's disease undergoing pretreatment evaluation? Or is this a patient on therapy in which we're monitoring for ARIA? At our institution, we've differentiated these by using naming conventions of AD therapy enrollment and AD therapy monitoring. We want this AD therapy enrollment exam to coincide with and be one and the same as our dementia brain MRI to prevent the need for repeat imaging. So we've therefore laid out our orders as that pretreatment enrollment MRI being an MR brain dementia with an indication AD therapy enrollment, and asymptomatic monitoring for ARIA is an MRI brain without IV contrast with the indication AD therapy monitoring. We want to distinguish these two very clearly as there's different relevant imaging findings for each of these scenarios. So next, we'll discuss the imaging protocols, which can be directly linked to those separate MRI orders. In all cases, we need 3 key sequences that are performed consistently across all serial exams of the patient. These are T2 FLAIR for ARIA-E detection, gradient echo or susceptibility-weighted imaging for ARIA-H detection, and diffusion-weighted imaging to differentiate ARIA-E from acute ischemia. In clinical trials, the FLAIR has traditionally been performed using a 2D technique, but either a 2D or 3D exam is acceptable, whichever can be performed consistently with high quality in your practice. For ARIA-H detection, gradient echo has been used in clinical trials, and that is the sequence on which ARIA-H severity scoring is based. However, susceptibility-weighted imaging is more sensitive and desired in many clinical practices. And it should just be noted that with the use of SWI, more microhemorrhages may be detected, and that may result in a more conservative treatment approach. In order to aid consistent imaging across serial time points in a patient, the American Society of Neuroradiology Alzheimer's ARIA and Dementia Work Group has partnered with MR vendors to provide specific ARIA imaging protocols for download, which have been attempted to be harmonized across their fleet. These protocols include these 3 key sequences. These are all 2D sequences that can be performed on all scanners and within under 10 minutes of gradient time. Should be noted, these are sequences included in all of our standard MR brain without IV contrast protocols. But in some standard practice protocols, the parameters may not be optimized. Particularly for the gradient echo sequence, the echo time needs to be appropriate, specifically 50 to 20 milliseconds on a 3 Tesla scanner. I'll show a few examples highlighting the importance of using a consistent standardized imaging approach. This is an example of a patient with both ARIA-E and ARIA-H microhemorrhages. On the first time point on the left in which ARIA was identified, we see several microhemorrhages. When they came back the next month, susceptibility-weighted imaging was performed instead of a GRE, and we see more microhemorrhages. However, it is unclear whether the patient has developed new microhemorrhages or if more microhemorrhages are seen due to differences in technique. Similarly, for the T2 FLAIR, a standardized imaging approach is needed to avoid ARIA-E mimics. So this is a case of the patient who had their baseline MRI performed on vendor A. When they presented for their 3-month post-dosing exam, it was performed on vendor B. We see apparent increased extent of T2 hyperintense signal in the occipital white matter, a common place for ARIA. So this was called possible ARIA-E, and the patient returned the next month for repeat imaging. We see over the course of serial exams that the difference in the appearance of the occipital white matter was due to changes in the scan vendor rather than the presence of ARIA. So for optimal ARIA detection, we want, again, a consistent standardized approach that includes a consistent set of sequences, sequence parameters, field strength, and vendor over serial exams in a patient. And this can be achieved using dedicated imaging protocols, as well as triaging patients to a specific set of scanners if feasible within your practice. And this all must be done with the awareness that many practices are also having the need to accommodate increased MRI scan volumes. Now we'll go through those relevant imaging protocols. So for the AD therapy enrollment exam, again, that is recommended to be one and the same as the dementia evaluation to prevent the need for repeat imaging between the times of diagnosis and therapy enrollment assessment. For the AD therapy monitoring exam, again, an MRI brain without contrast. In some practices, that is being done using an abbreviated protocol of just those three key sequences of the FLAIR, GRE, and DWI in order to help accommodate increased MR scan volumes. And finally, when there's a patient on amyloid targeting therapy presenting with new neurologic symptoms, this is the one scenario in which gadolinium contrast may be warranted depending on the patient's presentation. Next, we'll move on to reporting of relevant imaging findings. So again, we've differentiated those AD therapy enrollment and AD therapy monitoring exams because there's different relevant finding in each of those scenarios. So that baseline or enrollment exam is performed to identify any exclusionary findings for treatment, as well as provide a baseline for future comparison. Whereas on the monitoring exams, again, we're identifying ARIA and reporting a relevant severity score. So a few more details now on that AD therapy enrollment exam. We need to specify number of microhemorrhages, presence of superficial siderosis, extent of infarcts, and white matter hyperintensities, as these are used to determine a patient's eligibility for therapy based on risk factors for ARIA and adverse events. And here is an example reporting template for that AD therapy enrollment exam. This is a rather simplified template to make of findings that would generally be reported on such an exam. However, I think is important in order to remind the reader of the level of detail needed. For example, we need to provide a specific number of microhemorrhages in order, again, for the treating provider to have an accurate risk assessment. So rather than few scattered cerebral microhemorrhages, it's important to identify, is there 4 or are there 5, 6, or 7 microhemorrhages? On the AD therapy enrollment exam, again, we need to identify ARIA and, if present, provide a radiographic ARIA severity score. And here is a representative reporting template. So this quite more complex. Here we have separate sections for each ARIA-E, ARIA-H microhemorrhages, and ARIA-H superficial siderosis. And the goal here is to help bring the reader through the relevant findings and arrive at an appropriate ARIA severity score. So for example, for ARIA-H microhemorrhages, we want to report any microhemorrhages that were present on the pretreatment baseline MRI. These will not count as ARIA-H, but it is important that they are documented and brought forward on subsequent exams. We want to know if there are any treatment emergent microhemorrhages present on the prior exam. Are there any new microhemorrhages present on today's exam? And that will give us the total number of treatment emergent microhemorrhages, which will be used to determine our ARIA-H severity score. We can also use pick list, as shown here on the left, as sort of a cheat sheet for the reader to go from the findings to mild, moderate, or severe ARIA. So here is a summary of those imaging workflows for the 3 patient scenarios. And the final point that I'll mention is that in the case of moderate or severe ARIA, closed loop communication is warranted, as those findings will affect a patient's eligibility for continued drug dosing. Next, we will move on to a few cases. First case, the patient comes in with the indication of AD therapy monitoring. We first want to have for reference their baseline T2 flare shown on the left. And on the post-dosing, they have new left parietal, occipital, and temporal T2 hyperintense signal involving the cortex and subcortical white matter. This is measuring just less than 10 centimeters, so was called moderate ARIA-E see quite extensive. Dosing was suspended, and the patient comes back the next month for a repeat MRI. Despite no further drug dosing, the ARIA-E has progressed, now have extensive T2 hyperintense signal also involving the white matter, increased in extent, now greater than 10 centimeters, and severe ARIA-E. And we see the next month, this has dramatically resolved. This patient also had ARIA-H, and we're showing here on the top the T2 flare, and on the bottom the GRE. So again, post-dosing on when the ARIA-E was identified, there were a few new microhemorrhages. The next time point, we had progression of ARIA-E and also progression of ARIA-H with more microhemorrhages. And notably, even when the ARIA-E has resolved, we continue to see more ARIA-H microhemorrhages. And this is often the temporal sequence as events, as even when the ARIA-E has resolved, those heme products may continue to coalesce and the ARIA-H microhemorrhages may peak slightly after the ARIA-E. So this patient had greater than 10 microhemorrhages and severe ARIA-H. The next case is a patient presenting with unsteadiness, and brain fog with concern for stroke. So that current time point is listed at time point 2 on the bottom. And we have for comparison time point 1, which was a year earlier. We see in retrospect on that prior exam, there's patchy edema in the left occipital lobe, which has subsequently resolved. On the current time point, though, there is new right occipital edema, T2 hyperintense signal in the subcortical white matter, as well as a small sulcal effusion. There was no associated diffusion restriction. There were, however, a few microhemorrhages in the right occipital lobe. We also see a cluster of microhemorrhages in the left occipital lobe in the region of prior edema. So what is the diagnosis here? So here we have transient occipital edema and sulcal effusion and new microhemorrhages. So imaging findings very similar to what we've been going through for ARIA. However, this patient is not on an amyloid targeting therapy. So this is a case of cerebral amyloid angiopathy-related inflammation. It has a similar imaging findings and pathophysiology as ARIA, except occurs spontaneously rather than in the setting of an anti-amyloid immunotherapy. The next case is a patient presenting with altered mental status. We see again occipital T2 hyperintense signal involving the subcortical white matter. Like in the prior cases, there's no associated diffusion restriction, and in this case, no associated hemorrhage. Again, the history is key here. So this is a patient with rectal cancer on a VEGF inhibitor presenting with marked hypertension. And the diagnosis here is posterior reversible encephalopathy syndrome. So again, overlapping imaging findings of ARIA with a posterior predilection of flare hyperintensities, absence of diffusion restriction, and in some cases, there may be associated hemorrhage. The take-home point from these cases is that other processes may have similar imaging findings of ARIA, and the clinical history is key in the differential diagnosis. And specifically, is this patient on an amyloid targeting therapy? In summary, ARIA are imaging abnormalities of edema and hemorrhage that occur in the setting of amyloid targeting therapies. ARIA-E is parenchymal edema or sulcal effusion detected on the T2 flare sequence. ARIA-H is microhemorrhages or superficial siderosis detected on a GRE or SWI. For optimal ARIA detection, imaging, and ascertainment of ARIA should be performed in a consistent fashion, and that may be aided by use of dedicated orders and imaging protocols. And finally, clinical history is key in differentiating ARIA from other processes. So thank you for your attention, and at this time, I'm happy to take any questions. So the first question is, what is meant by recent brain MRI prior to treatment? So the FDA labels specify that a recent brain MRI is needed prior to treatment to evaluate for those exclusionary findings. In appropriate use recommendations, that is clarified as within 1 year prior to the initiation of therapy. And in many cases, people have thought closer to 3 to 6 months prior to therapy, ideally. And that is particularly in patients who may have a couple microhemorrhages on, let's say, an MRI exam 1 year prior. Those are cases where, for a more accurate risk assessment, it would be better to get an exam closer to the date. And I'll go on to the next question is, how do you report findings if you acquire both a gradient echo and susceptibility weighted imaging? So there are some practices that are doing RAH assessment just with a GRE, some using just an SWI, and there's other practices that are acquiring both of these. And we are doing that and recommending that people use both sequences to provide one number of microhemorrhages, what you think to be the true number of definite microhemorrhages based upon the use of both sequences. And there are cases where we say maybe the GRE is more specific for a microhemorrhage, but the SWI more sensitive, and that we can use the information from both of those sequences as well as other available sequences to help us determine potentially a microhemorrhage from a vessel. The next question is, how helpful is gadolinium contrast to differentiate mimics from ARIA? Generally, in the ARIA assessment and in a typical AD therapy monitoring exam, that gadolinium is not necessary, and that with the appropriate clinical history and diffusion weighted imaging, a big help to differentiate ARIA from ischemia, we can usually work out the pathology. I think where gadolinium comes in to play is, again, if the patient is symptomatic, and particular if they have imaging findings that or clinical symptoms that don't fit for ARIA. And so those where either the clinical presentation and imaging findings are discordant, or if there is a case where at initial exam on a MR brain without, it looks like ARIA and is treated as such, but if the imaging findings do not evolve as expected, then an exam for further evaluation with gadolinium may be warranted. The next question is, can I use a CT to evaluate for ARIA? And CT is not adequate to evaluate for ARIA. So we would expect that in a case of moderate to severe ARIA, so that would be is larger regions of ARIA, that would be, you could see that edema on CT. However, smaller regions of ARIA-E would not be detectable. And for example, if a patient has multiple small, say 1 to 2 centimeter regions of edema, based upon the multiple regions of discontiguous signal abnormality, that would be moderate ARIA-E, but in that case, it would not be detected. It would only be those larger regions of edema that we would be able to confidently see on CT. So, and ARIA, small ARIAs of ARIA-E not adequately detected on CT, and also ARIA-H, microhemorrhages, and superficial siderosis would not be able to be detected on CT. So at this point, we're going to wrap up our webinar, and we thank you for your attention, and we hope that you have a wonderful afternoon.